Hi, and thank you for joining our webinar, TPLO Physical Therapy Justified. A special thanks goes to Hudson Aquatics for sponsoring this webinar. My name is Dr. Caroline Adrian. I am the owner and founder of Canine IQ, a hybrid educational and training program for physical therapists to treat canines confidently, and an independent research consultant. You're not in this field for over 25 years without supporting your favorite companies, and I gratefully acknowledge sponsorship from several of our industry partners, specifically Hudson as our premier sponsor of Canine IQ, as well as SpectraVet, our go-to for lasers and photobiomodulation devices, MediVet, Paw Prosper, Walkabout, Dog on Wheels, and Canine Motion. These partnerships help to advance our educational mission, and no sponsor has influenced the content or conclusions of this presentation. I started my career at Alameda East Veterinary Hospital, developing their physical therapy department, and moved to be Director of Rehabilitation Services for VCA Animal Hospitals. I am the past Vice President of the Orthopedic Section Animal Physical Therapist Special Interest Group within the American Physical Therapy Association. And as I mentioned, I am the owner and founder of the hybrid education and training program, Canine IQ, for physical therapists specifically, and also am a past student of Colorado State University, earning a doctoral degree in canine biomechanics, as well as a member of the International Association on Veterinary Rehab and Physical Therapy since its inception back in 1999. A little bit more about me. I have 2 skin children and several fur babies. Our family looks a little bit different these days, but they're the ones that keep me going and grounded. The culmination of my career came in 2021 when I was voted by my peers as the Veterinary Rehabilitation Therapist of the Year by the IAVRPT. I have several publications, including Contributions of Motor Learning and the Physical Therapy of a Working Dog. This report discusses physical therapy of a Rottweiler with a C5-6 IBDD that ended up having a rhizotomy and was tetraplegic, as well as publications related to my PhD that focus on muscular activity related to the cranial cruciate ligament. We review the canine stifle joint for a brief moment, or the canine knee. It is formed by 3 articular surfaces, including the femur, the tibia, and the patella, and joined by a series of complex ligaments. The focus of this particular webinar will be on the craniocruciate ligament, but biomechanics of the stifle joint, the cruciate ligaments, cranial and caudal, as well as those collateral, medial and lateral collateral ligaments and the menisci, help to provide stability for the canine stifle. The cruciate itself means to cross, and that provides resistance of motion in all planes. Going through my doctoral dissertation, one of the subjects that was missing within veterinary medicine is the concept of motor control, where muscle activation we know plays a large role in joint compression and stability of those particular joints. And in human ACL deficiency, we know that there's a role of muscle activity in supporting joint stability. When we see asynchronous timing of muscle onset, timing, and amplitude, we know that that's going to affect stability, kinematics of the joint itself, as well as joint loading. And when we have inefficient muscle recruitment, it's going to increase periarticular structures to mechanical injury or the point of failure. When we talk about neuromuscular control, during stretch, we know that those receptors within the intra-articular, periarticular structures are going to increase their firing of the alpha motor neuron, which is going to increase muscle stiffness and therefore stability. This is one of my favorite videos, courtesy of Dr. Scott Tashman out of the University of Pittsburgh, who's now actually here in Colorado at the Steadman Hawkins Clinic. He looked at these videos of the canine stifle, and you can see an intact cruciate on the left versus a cruciate deficient stifle on the right. And if you'll notice the instability within all three planes of motion. We know that the effects of craniocruciate ligament rupture are many, including joint instability, whether that's human or canine. We see a shift in joint contact area as well as increased joint contact forces, which then requires an increased reliance on muscle and muscle activity. Decreased weight bearing and decreased peak vertical force is very common. Dogs tend to stand with increased stifle flexion. Osteoarthritis will set in over time. And joint effusion, where joint effusion may cause muscle inhibition, we know in humans, but does that also affect the canine stifle, as well as muscle weakness in humans? So here's our limitation and gaps in the knowledge. We know that there's concurrent regulation of the muscle spindle sensitivity to stretch within the neuromuscular control. That happens via the gamma motor neuron system. So when there's injury to the ACL, we get a loss of joint afferent signaling, which decreases the gamma motor neuron signal, reducing muscle activation and therefore decreasing joint stability. We know that with craniocruciate ligament rupture, that's the most common orthopedic injury in a dog. And I put together a care map. I don't like the term protocol, which implies that it needs to be followed the exact same way every single time, and that's not the case that we know in canine physical therapy and human physical therapy for that matter. It's extremely important that you evaluate and reevaluate that particular patient every time you see them. We have a general care map for the TPLO that we will discuss and work through. First questions when you're addressing a post-TPLO patient, and even before you see the patient, is what type of surgery was involved? What tissues are involved? Of course, we are talking about the TPLO here in this particular presentation, but it's really important to get your hands on the op report from the surgeon themselves. What tissues were involved depending on the type of repair, how long ago was the surgery, who did the surgery, and how much OA is in the joint, if that's even known. Again, when addressing any type of surgical repair or injury, it's extremely important to understand your average timeframes for healing, meaning very tissue specific. Is it a muscle? Is it a ligament, a tendon, and other types of injuries? And this just gives a general guideline for your average tissue frames for healing. That's the primary thing with motor control. With first things first, we talked about the proper tissue healing depending on the type of repair and have you gained the range of motion back. And then we can start looking into a variety of motor control strategies via physical therapy to improve the motor control post-operatively. Primarily with human rehab of cruciate ligament repair. We look at isometrics, isotonics that are targeting quadriceps, and here are just a few examples of different activities and exercises that we can incorporate in our human patients with parameters basically set around each patient. You know, there's no specific number. You want to be watching for poor form or what we call ratcheting of the knee. that's going to indicate that they've lost motor control. And at that point, you need to stop and start again, most likely at another time, because we want to train to fatigue, but not into or beyond fatigue of that particular area. And similarly, when we talk about physical therapy in our canine patients and addressing motor control, we must first identify where that muscle weakness is, where those primary deficits are, before even considering developing a strengthening program. And just by removing inhibitory sources that may prevent or delay muscle activation, can we reduce those activation deficits? For example, just getting rid of joint effusion prior to focusing then on these neuromuscular retraining programs. So let's look at my TPLO home care map, and we'll look at and break this down into smaller components based on our timeframes for healing, based on the tissues involved, and everything we talked about previously, and then understand how we can justify taking this back to your surgeons who may be skeptical of physical therapy post-operatively, and talking them through this in an evidence-based way. So first, to simplify these post-op principles, we're going to break it down into 5 segments of physical therapy. First, we want to reduce effusion and pain, then focus on neuromuscular reeducation, restoring full range of motion, normalizing proprioception and kinesthesia, and only then are we going to start restoring strength, power, and return to sport considerations. So let's break this down. First, we're going to target reduced pain and effusion. And my go-to is laser photobiomodulation. We know that that's not a thermal modality. If anything, you may see 1 to 2 degrees increase in tissue temperature, always using caution, especially on dark fur. We also understand that laser can reduce our PGE2 levels, TNF, down regulating the COX-2 expression, and ultimately reducing the pain and swelling within that particular targeted region. One of the more interesting studies was from almost 20 years ago, where they actually found no difference in anti-inflammatory effects between utilization of laser and NSAIDs. So they were able to reduce these specific inflammatory markers and achieve the anti-inflammatory effects of laser, very similar to the use of these pharmacologic agents. Sticking with our principles of post-op physical therapy to reduce pain and effusion, cryotherapy is also extremely effective to reduce pain, but does not have an effect on range of motion. It can also decrease quadriceps inhibition that we see in our human patients, which ultimately then would increase power within the knee itself. Cold compression is known to be more beneficial than just cold packs alone. We actually looked at a cold compression unit. This is probably almost 20 years ago and never published the data, but we did 2 treatments. The first treatment was 3 hours post-surgery. The second treatment was day 2 post-op for a total of 15 to 20 minutes of total treatment time each. And we found a decrease in thigh circumference of 2 to 6 centimeters. It was pretty impressive. And we know that cold compression is more effective at deeper tissue levels. Moving on to our second principle of post-op physical therapy, or neuromuscular reeducation. We know in people that effusion within the knee can cause profound inhibition of the quadriceps muscle, contraction of that muscle. And we also know that weakness within that quadricep muscle is very pervasive after rupture of the human anterior cruciate ligament. And looking at morphologic studies, the relationship, there's very little relationship actually between the amount of atrophy and weakness. That weakness, that persistent weakness within the knee comes from the reflex inhibition or incomplete quadriceps activation. That's where we need to start incorporating neuromuscular retraining, looking at EMG biofeedback, neuromuscular e-stim, proprioception, balance training, perturbation training, even vibratory stimulation to regain that reflex inhibition and focus on neuromuscular re-ed. The cryotherapy can actually disinhibit that quad muscle after joint effusion. So important to also apply cryotherapy post-operatively as well. Our third principle of post-op physical therapy is restoring full range of motion via passive range of motion exercises. You don't want to do too much activity, too much strengthening, too much forced exercise until we can get that full range of motion back. We know that that's safe to begin range of motion, passive range, as soon as pain allows post-op. It's going to avoid problems with fibrosis, and we know that early motion is going to reduce pain, decrease the adverse changes in articular cartilage, and prevent capsular contractions. Within our hospital, we implemented the TPLO care map in an inpatient setting immediately post-operatively. As the dogs were intubated, that cryocuff was applied. Obviously, this isn't a knee, but similar concept. We would apply that cryocuff immediately as the animal is waking up for surgery. Either the physical therapist or the surgical techs were trained to perform this technique. We did that Medivet cryocuff, also doing SpectraVet laser at a different time prior to discharge, and then talking to our clients at discharge related to levels of activity with no running, jumping, playing, talking about and demonstrating passive range of motion, icing, and of course the activity restrictions. So let's start with the principles of post-op physical therapy, looking at the full TPLO care map beginning from weeks 0 to 2, or the acute phase. And we start with passive range of motion, understanding that this technique requires no voluntary muscle contraction. The movement comes from us as the clinician, from an external force, and the goal is to protect the healing tissues. We use it when the animal is not able to actively move or is not supposed to actively move a body segment, when there's inflammation present, when active range of motion is painful. The early range of motion is performed to nourish articular cartilage, alignment and organization of collagen tissue, and we use passive range of motion activities to prevent formation of scar tissue and adhesions, minimizing the occurrence of contractures. So the goals of the use of passive range of motion within the immediate acute phase is to minimize the effects of immobilization. We want to reestablish non-painful range. Typically, we're staying within mid-range rather than going to the extremes of flexion or extension, decreasing pain and inflammation, and reducing muscle atrophy. Continuing our TPLO care map within the first 2 weeks or acute stage, we are instructing the client for what I call potty breaks only. The dog is on a short leash, goes outside to go to the bathroom 3 to 5 times per day. This requires control of the animal, so they're not out in the yard running around. They're tight up next to the owner, outside to go to the bathroom, walking around, sniffing, and coming right back inside. The passive range of motion, I typically perform or have the client perform 10 to 15 reps a couple of times a day, could even go up to 3 or 4 times a day, of the hip, the stifle, as well as the hock. So we're not just focusing on the cruciate, the stifle itself and the cruciate repair, but also the connecting joints above and below the surgical repair site.
Icing, you can continue. I instruct the owner once or twice a day, typically right after passive range of motion and outdoors to go use the potty. And I'll have owners ice about 10 minutes before the animal really gets antsy. And you want to make sure that you have some sort of a wet cloth between the ice pack itself and direct contact with the skin. And at this point, I'll educate the owner right at discharge. Myself or the technicians will discuss with the owners the time frame for bone healing, what the surgery itself looks like, use of a towel, especially on slippery surfaces. All of our dogs go home with a harness system that provides the owner some sort of contact to support the animal while they go outside, especially on slippery surfaces. Instructing the owner, as I mentioned, on passive range modalities such as the icing, and that sutures will need to come out in a good 10 to 14 days to please schedule an appointment. And at that point, when they schedule for the suture removal, we schedule back to back for the initial physical therapy consultation. I'm instructing owners to monitor the animal's response. Are they more and more comfortable in using the limb? So often we see these dogs go home non-weight bearing, and by the time they come back for their initial physical therapy consult, they're at least toe touch weight bearing. Looking for stiffness, increased stiffness, and as I mentioned, increased limb use, and continue to restrict activities, no running, no jumping, no playing. Should they note persistent swelling, any type of sharp cries, yelps, changing the way they use their affected limb for the worse, consistent licking at the incision, certainly call physical therapy or call your veterinarian immediately to address those issues. Now, continuing through my TPLO post-op care map and justifying whether to use the treadmill or not within this acute phase of 0 to 2 weeks, I only have clients and educate clients on these controlled potty walks only. I do not start an underwater treadmill at this stage. Those controlled leash walks are outside to use the bathroom and to come right back in. And the reason I don't focus on underwater treadmill this early on is due to timeframes for bone healing. We're looking at just the initiation of callus formation at about the 3-week mark. So I don't want anything to potentially disrupt that callus formation. Looking at Wolff's Law, we know that bone will adapt to the loads that it's placed under. So if the load increases, that bone is going to remodel over time and become stronger and resist that increased loading. So if I'm out there forcing load, forcing activity on that surgical site, there is the possibility of delayed union with callus formation. I want that callus to form before I start to stress it. And along those lines, let's move into the TPLO post-op care map. We're still sort of in the acute phases. Around weeks 2 to 4 is where I start these muscle flickers, or what I call a muscle flicker, which is essentially a weight shift. So we talked about that callus forming at the 3-week mark. Now I'm going to kind of pile on, if you will, and start to stress that callus just a little through isometrics. These muscle flickers are very light contractions where that muscle is turning on and off very, very quickly. It's a very small mid-range isometric contraction. I don't want to stress the joint too much or the soft tissue too much. And it's more of a muscle contraction that's going to benefit the tissue healing. So we know that mechanotransduction is deformation of the muscle links the mechanical forces with biochemical signals, And we're going to increase vasodilation to those working muscles, increasing blood flow and immune responses to clear that damaged tissue. So in the top right, that picture is just an example of my handout to clients where I demonstrate muscle flickers, squaring the dog. Oftentimes what you will see is they want to kick that leg forward, the affected limb, the surgical site. They want to either abduct it out to their side or kick it forward to offload. So I do square the animal up and encourage weight bearing, but I want to emphasize this is not a forced activity. Once I square the animal and I shift side to side, front to back within that mid-range, you may only get 5 to 10 seconds worth of muscle flickers before that animal says, okay, I'm going to kick it forward or out to the side again. I'm not comfortable. That's where you stop. So I may repeat that 5 to 10 seconds, 2, 3, 4, 5 times, depending on tolerance of the animal, before I stop. And perhaps you only get 30 seconds of this, 5, 10 seconds each time, up to perhaps 30 seconds, if that. So monitor the animal's response. It's extremely important that you follow what the animal is comfortable with. And over time, you will start to see that improve, and the animal begins to tolerate it longer and longer. Continuing with our TPLO care map for weeks 2 to 4, we are stopping passive range of motion. There is no need to continue passive range once we start to see the animal's weight bearing improve from non-weight bearing to toe touch to partial weight bearing. Again, if you're not seeing that progression, go back, talk to the surgeon, discuss potential problems related to the surgical repair or possible infection, whatever else might be going on. At this point, I also stop sling support for urination defecation as the animal becomes more comfortable weight bearing. Now that's a bit of an asterisk because if the owner does have stairs or require stairs, some owners live on a second story and they have to be doing stairs. I will still use sling support to offload as the animal goes up the stairs. And if they have slippery surfaces as well, I may consider still use of the sling. So it's very patient and circumstance dependent. Here we are now continuing our short potty walks, as I call them, several times throughout the day. This is not a consistent pace. I am allowing the dog perhaps a little bit more time in the backyard to stop, sniff, stop again, walk around, leaving it up to the animal to determine their pace. So this is not a walk down the street to the stop sign and back. This is allowing them a little more time to stop, sniff around, and go to the bathroom. Here's where we're starting the muscle flickers that I consult and discuss with these owners. Standing square, I sit behind them with one arm under their belly. Perhaps you can even put their legs between yours if you're kneeling on the ground so to keep them from abducting out. But this is that mid-range, very slow, gentle, forward, side to side. Be careful you're not pushing so much that it pushes them off balance. This is not a huge movement. This is not a strengthening exercise. As I mentioned, we do it up to 30 seconds to tolerance. You will see this improve and their tolerance increases with time, repeating several times each and throughout the day. Continuing through the weeks 2 to 4 post-op TPLO, we're going to continue to target compensations, applying scar massage, maybe perpendicular to the length of the incision if that's indicated, potentially applying ice after the potty walks. I usually do this maybe once in the evening after all of the activities throughout the day, after all the potty walks, and again using that thin kitchen towel between the skin and the ice pack. The other instruction that I add here, excuse me, is the gentle joint compressions. I am not forcing this activity as well. This tolerance will continue to improve. I'm asking the animal to stand square again, getting behind the animal and providing those joint compressions, typically through the pelvis directly into the floor. I'm continuing to instruct owners on problems to note if there's still that persistent edema, any acute cries, or change in the use of the limb. Contact me, contact their veterinarian. The other instruction that I talk to clients about is if they see increased soreness, if they're seeing increased discomfort, increased fatigue, certainly call me. But cut that activity, whatever you've been doing, cut it in half and begin again from there. So perhaps we try to decrease the amount of activity if they're becoming too sore, that it's too much too soon. The fourth aspect or principle of our post-op physical therapy justified is normalizing proprioception, that normalizing gait mechanics. So we know that balance deficiencies in both lower extremities occur after ACL rupture in humans. So it's not just the affected limb, but in the contralateral in people as well. So that early weight bearing is going to enhance restoration of your proprioception. We want activities in multiple planes with early weight shifts, thus the muscle flickers, as well as the perturbations that you can start always beginning on the ground, progressing to the unstable surface, do both limbs. And that's the important aspect here as well. Progressing up to a single leg stance and stress on the affected limb. So let's justify that fourth principle of post-op PT in normalizing proprioception. Several articles here that talk about beginning on the ground with proprioceptive activities. So we understand that there's safe reactivation, retraining of that joint position sense, the neuromuscular control, that postural stability, decreasing excessive compensatory motion or risk of re-injury. And then we progress to the unstable to challenge balance, challenge that reflexive control as the motor systems, the sensory motor systems adapt and muscular co-contraction improves around the affected joint. Here we're now enhancing dynamic stability and functional recovery. One of the things I want to emphasize here as well is the importance of the core, especially in our four-legged patients. If you think about what connects the front limbs to the rear limbs, it's the core. So it's something you don't want to forget, that butt and gut phenomenon. You may have strong extremities, but the core is weak and you're not going to be able to provide enough force to produce efficient movements. If you have a weak core, you're going to cause some inefficient movement, which ultimately leads to injury. So don't forget the importance of the core. Some of those exercises may include the one-legged, the diagonals, the challenge standing, the ball, the peanut, the disc exercises that we see so often in this field. But note where I'm starting to apply those. These exercises are a little bit higher level. We want to start on the ground, moving towards some of our peanut and balance and unchallenged exercises. And finally, our fifth principle of post-op physical therapy is now we're looking at return to strength, return to sport, power. This is where we see the resistance, the cross-training. This is where I start hydrotherapy with the underwater treadmill. The Hudson is my preferred go-to for weight bearing, where I can control speed, I can control water height, and only then at the 4-week mark is when I begin underwater treadmill. And at that point, it may only be several minutes. I give a lot of breaks early on. We may only walk 10 to 30 seconds, give a rest. We may repeat that. Constantly watching for changes in the use of the limb. Once the animal starts to compensate, and you'll know, that could be a whole nother discussion, but we can see the animal tries to turn around, it becomes more lame, it tries to offload, the gait changes significantly. At that point, you may be done, and it may only be a few minutes into the underwater treadmill treatment. I typically see these dogs once a week, starting at treadmill at the 4 week mark, as I mentioned, and going once a week until they get their final post-op x-ray at about the 8 week mark. And I usually see them once more after that, and they're usually at that point 80 to 90% healed. Then we start our straightaways, our cuts, our turns, varying surfaces, varying gaits, increasing running and jumping and playing, and the power and the multi-joint exercises and movements. But that's not only, or that's only, and once I get that post-op x-ray at the 8 week mark, and then I gradually increase those return to sport activities over the next 4 weeks from 8 to 12 weeks. Continue through the care map that I provide to my owners. Here we are at the 4 to 6 week mark. We're continuing to progress our therapeutic activity, increasing our slow leash walks, 10 to 15 minutes, a couple of times a day. Allow them to stop and sniff, but now we're starting to encourage a more consistent pace. And my general rule is to increase those walks by about 5 minutes each week, always to tolerance. And now we're starting our functional strengthening. Here's where I mentioned we start the underwater treadmill with the 3-legged standing, the diagonal standing, figure eights in a very wide circle. So I'm not stressing those cuts and turns too early. I mentioned the proprioceptive activities, the perturbations first on the ground and then progressing to those unstable surfaces. And on occasion, I will provide laser for some of those post-exercise swelling. And here again, I'm talking to clients about at any point during this healing and PT process. If you have any questions, to please reach out to me for discuss those questions or concerns. One of the best uses of the underwater treadmill, I feel, is with these TPLO patients. I can intervene earlier in the recovery period, thus boasting outcomes of 80 to 90% healed at the 8 week mark when I get that post-op radiograph from the surgeon. I can promote that early range. We have seen some of the kinematic articles out there that show the increase in range of motion, not just at the stifle, but also at the hip and hock joints as well. And we're providing that resistance throughout the kinetic chain. Gait training, improved flexibility, cardiovascular function. We've seen a lot of these benefits, of course, diminishing concussive forces by reducing the gravity, and of course the warm water. I typically keep my water in the mid 70s, 70 degrees Fahrenheit, 75-ish. I found that anything higher than that, they tend to pant a little bit faster and fatigue faster. And of course, we can also get our older animals in there to exercise effectively. Great picture of our hydrotherapy, strengthening with resistance. I can start to increase as the animal continues to improve. I'm talking to those clients to get the feedback. Hey, how'd your dog do after our underwater treadmill session last week or last visit? And now I can start to increase that strength with resistance of the water to improve endurance, cardiorespiratory endurance, range, of course, joint protection continued with flexibility, and the animals absolutely love it. Let's look at some of the human literature to justify our hydrotherapy. Of course, it's a little bit different in people. We see 90% less weight bearing when we're submerged up to our neck, and movements in water produce only concentric muscle contractions. Thus, that delayed onset muscle soreness is minimal and almost completely eliminates the possibility of bone, muscle, and joint injuries. Of course, We have to monitor the patient in the water at all times because they can't communicate any type of discomfort to us. Buoyancy of dogs is a little bit different because of the quadruped stance, but we know that most of the time, dogs were weight bearing about 60-40 front to rear. That doesn't change very much as we increase the water. The biggest thing is the 38, almost 40% weight bearing decrease in the dogs when we fill it up to about greater trochanter height. So the potential concern is a little bit more of a shift to the front end because of that cantilever head that still remains out of the water. For my dogs in the underwater treadmill with TPLO, I tend to go about mid-thigh. That seems to be the most comfortable for them. Again, just clinical experience. Not sure that we really have a lot of data to show that higher or lower may or may not be better. As we discussed previously, the stress on the bone, or Wolff's Law, is one of the most important aspects of the physical therapy rehabilitation protocols for our post-op TPLOs. I want some degree of weight bearing. I want some degree of stress on that surgical repair when appropriate. And you can actually see these are similar treadmills. The only thing we did differently here was to dig a pit and drop that treadmill in. So as we open the door, it's even with the ground. So it is a little bit easier for some of our post-op patients where they don't have to jump in. Of course, you could use a ramp, but it's nice for the neuro patients as well where they can just step right into the treadmill without concern. I talked a little bit about when I began the hydrotherapy and why. I do want to emphasize that no, I don't think hydrotherapy is for all dogs. But when it comes to treadmill, underwater treadmill versus swimming, I will almost always target hydrotherapy, at least for TPLO, utilizing an underwater treadmill. If you think about swimming, it's a much more ballistic movement. There's a higher potential for injuring themselves, especially if the animal's never been in a pool before. And often what I have seen is the animals will use their front limbs more, just tuck up their rear. That's where they get the term doggy paddle, right? So the exercise, the activity comes when the front limbs and they tuck up their rear and just float their hinds. So the underwater treadmill provides more of a self-contained, controlled environment. Can't tell you the last time I added jets. Does it make a difference? The jury's out on that. The other reason why my go-to is an underwater treadmill over a pool is not so much for TPLOs, but the spinal extension. As an animal gets into the water, it's more forced spinal extension. So probably more for our neuro patients, our post-op IVDD, I avoid spinal extension, at least until the 8-week post mark. And then, of course, with the underwater treadmill, I look at forced hip extension. So you'll see these dogs cheat as well. Again, not so much with TPLO, but perhaps with hip dysplasia. Dogs that don't have the range, that are where the range of motion in the hip is not targeted initially, we start to see them protect that hip. So as the tread itself pulls that limb back, these dogs are coming up into swing, initiation of swing phase faster, trying to guard that hip extension. So it's very, very important that we improve the range of motion first before we utilize the underwater treadmill. The introduction, when I introduce an animal to the underwater treadmill, I can't tell you how many clients have said, "Oh, my dog hates water." My response to that is give me a chance. You'd be surprised when they can touch the ground. This is also one of the reasons why I like the underwater treadmill over swimming. Animals feel a lot more comfortable. when they can touch the ground. So if they are trained to a leash, almost always I can get them comfortable in a treadmill. So I have the animal, oftentimes I'll just jump in with them without the water and put the animal in, shut the door. We'll just kind of walk around, let the animal sniff a little bit, allowing them a loose leash the whole time. So then I start to fill the water. I start slow, I'll start to fill the water. Sometimes the noise can be a little bit daunting. And as that water gets higher and higher, sometimes I can see the animal get a little bit concerned. So I keep a loose leash. I may start it at carpal height, and just allow the animal to walk around. I'll go to the other side, asking them to come, forward. Here's a little bit of a treat. And then we come back in the direction that I want them to walk. As they're coming back to me, I start the underwater treadmill, giving quick tugs on the leash, for maybe 5 or 10 seconds, and then continue to fill as the dog continues to walk. Here's my summary slide of the treadmill versus a pool. I mentioned the pool being more ballistic, increased risk for injury, less control. I feel that the pool is a much higher level of activity, especially when you incorporate jets. They're having to work harder. I use pools more for resistance training in healthy dogs and just for fun, and more for cardiovascular exercise versus the treadmill, forcing passive range of motion, more of a weight bearing controlled environment. And it allows for more increased freedom for me. Oftentimes, I'm talking to clients, I'm writing my notes or typing my notes as the animal is working in the underwater treadmill. Let's move on to my care map post week 6 through 8. We're continuing to increase the intensity and the duration of those therapeutic activities, including the longer leash walks and a little bit of a longer lead. So the animal's out in front, they can move side to side, incorporating those cones or figure eights. I'm starting to narrow those turns a bit, incorporating inclines, declines, continuing the underwater treadmill. Swimming, if they would prefer, no explosive water entry, so I don't want the dog to be jumping into a pool. They can wade in and swim from there. And starting a little bit of trotting to tolerance, of course, for all of these activities. Continuing my proprioception, and as I mentioned too, the radiographs to confirm the healing at the 8-week mark. We're seeing 80 to 90% healed at that point. Here's where we continue to progress over those last 4 weeks. That last month, I usually see the dog one more time at the 10-week mark. Often the surgeon chooses not to do radiographs. If they're 80 to 90% healed at the 8-week mark, off they go. Go see Carrie one more time for the final checkup. If the leg is not fully healed at 8 weeks, as indicated, often the surgeon will want to do one more radiograph at the 12-week mark. So then we'll take a step back with our activities. This is pretty rare, but I instruct owners to go back to the post-op week 6 to 8, starting to stress that limb. Excuse me. Continuing to stress that limb with increased activity, short off leash, more stairs, zigzag trotting, short bursts. And our final is returning to the prior level of activity at the end of the 12-week mark. At the end of that post-op week 12, I want to see that stifle free of inflammation with full range of motion, potential for equal muscular development between affected and contralateral. To be honest, it's pretty rare that I do thigh girth circumference. I go more off of gait and feel that osteotomy is complete, and we surmise that the progression of OA has been at least slowed, if not halted. One of the big things to note is that your patient may be referred to physical therapy or rehab at very different phases of healing. And this is why it's so important to be able to evaluate and reevaluate every time you see your patient. Read uh, the surgical report, read the op report, what tissues are involved, and know where we are in those time frames for healing, and pull that in with your hands-on examination. But what can go wrong? You know, majority of our patients fly through our physical therapy program, home care program, with no issues. But of course, we're always going to, see those one-offs that may have a problem. And when do we go back to that surgeon or the referring veterinarian? We want to know that repair is stable. What's going on in the contralateral stifle? Are you seeing concerns or increased weight bearing? And sometimes when there's bilateral cruciate ruptures, you're so focused on the affected that once that is stable, now we start to see problems and increased lameness in the contralateral. What do the radiographs show? Are the screws starting to move their way out? Is that animal uncomfortable on point palpation? Let's look at the lameness. Is that getting worse? Is there a meniscal tear? Is there infection? Always check lumbar spine and SI. I can't tell you how many dogs I see that have had a TPLO that end up having SI dysfunction. And people are, everybody's wondering, why is my dog not improving? Don't just focus on the stifle, focus on the whole dog. Could it be patellar tendinopathy? Is the plate uncomfortable and backing out for some reason? So all reasons to assess and reassess every single time you see that patient, and know when to pull in the referring veterinarian and the surgeon. I do want to share my preferred physical therapy vendor contact list. You're not in this field for 25 years and not have your favorite vendors. Of course, I'm very, very grateful to Hudson as our premier sponsor, but also to Peter Jenkins with SpectraVet. If you're looking for lasers, those are my go-to. The orthotics, prosthetics, Paw Prosper, Dog on Wheels, Walkabout are the harnesses that we use post-op, as well as Canine Motion. And of course, thank you to Hudson Aquatics for sponsoring this webinar. We are very grateful for your products, and use your underwater treadmill on a daily basis. If you're a physical therapist interested in transferring your knowledge and skills to a canine population, feel free to check out canineIQ.net or contact me at info or at Carrie, Carrie, at canineIQ.net. Here again, if you have any questions regarding TPLO physical therapy or PT in general for animals, feel free to reach out to me directly at Carrie at canineIQ.net, or for underwater treadmill questions to Nate Roth at Hudson Aquatics. Thank you for your time and for joining us.